webinar, um, Digital Health Myth or Reality, hosted by Villgro, with partner HITLAB. I'm going to be moderating this webinar today. My name is Arun Venkatesan. I'm the co-founder and CEO of Villgro US. We are hoping to start and mobilize a global network of social enterprise incubators, much like Villgro India, Villgro Kenya, Villgro Philippines, so that we can scale our impact to 3 times of what we are today and maybe in a quarter of the time. That's our hope. We have a very provocative title today, but we have policymakers or advisors to policymakers, practitioners, corporate innovators and entrepreneurs on this panel. And we hope to present like an on-the-ground picture of where digital health stands and its future in the next hour or so. My colleagues Akshita, Janan and Azar are sort of running the show here. I thank them right up front because usually people forget to thank at the end of the webinar. If you have questions, I want to remind you to put them up in the chat window so all of us can see it and then the appropriate panelists can address it. At the end of the seminar, there will be a survey too. Please make sure that you fill it out so that it gives us tremendous insights into what is required, what you're looking for and all that. I'm just going to very briefly introduce all the esteemed and experienced panelists today and then head right into the webinar topic discussion. So with us, we have Kiran Anandampillai, advisor technology with the National Health Authority. He's also been played a tech role in the UIDAI. He's happily agreed to talk about how policy is addressing digital health and has some exciting updates about the national health stack and so on. So please look forward to that. We have Madhubala Radhakrishnan, founder of mCura, an entrepreneur. mCura is a healthcare IT solutions provider. Madhubala has been in the mHealth domain for almost a decade now, right? Also joining us is Stan Kachnowski, director of the digital health program at Columbia. He's also chair of HITLAB New York, our partner for this event. With us is Kalyan Sivasailam, founder of 5C Network, the teleradiology solutions provider. I'm very excited to say he's one of Villgro's past incubatees who I had the good fortune to mentor. And rounding up this diverse panel is Biten Kadrani, head of R&D, Vision Care APAC at Johnson & Johnson. Biten and I have been on the fellow advisors at the Fire Design Founders Forum and many other forums like that, and Biten is a great friend. So welcome all. I think I'll just dive right into this topic with some updates from the field, so to say. So I'm gonna open up the floor to Madhu. Madhu, I know at mCura you've been fighting an uphill battle in implementing mHealth systems, digital health in general. But I know COVID-19 has changed all that, right? And I hear that it's in a good way. Can you fill us in a little bit on what you're seeing, what's happening in digital health, what avenues have opened for you?
Thanks, Arun. So digital health before COVID, two major issues. One was adoption and second one was who pays for it. So because of lack of adoption, we couldn't penetrate much in the healthcare industry. But during COVID, when the revenue dependent on technology, people started adopting it. That's the fact. Last 3 months, OPDs were closed and patient couldn't go to the OPD. The best way that everybody immediately adopted was the video consult one. And before COVID, we had this feature and we were telling them to use it for at least review patients. They don't have to come all the way from Himachal Pradesh to Delhi. You can have review calls by video, but they didn't listen to it. They need to come to hospital. Then only they were satisfied. Now, in last 2.5 months, we have seen tremendous increment. More than 8,000 calls being done, video calls from one hospital, and more than 2 crores revenue being generated. And this is really time for digital health to penetrate. And this period we have to utilize and transform the health industry so that people understand the importance of digital health. Because the minute revenue dependency and all other services is around digital health, people start realizing how important it is for their day-to-day life. So this is the truth today.
But this increase also means this scaling up, this rapid scale up also means there are certain requirements in the ecosystem that you need, right? So are you seeing any roadblocks? Are you seeing any concerns being expressed? I know people are being forced to adopt because revenue is a great driver for change. But are you seeing any other major barriers that you think need to be cleared, need to be addressed?
The major barrier, see, this should not be a one-time hike, and tomorrow if everything becomes normal, it should not get fade away. So what is that it needs to be done to stay? That we need to find. And also this should be a stream of one stream of service which should be always existing in the health ecosystem. Today they all use digital technology, and tomorrow it should not be the case. We are back to normal and we don't want it. So how can we create a hybrid model that this always exists, coexist, and we serve the complete health industry? And moreover, the record upload and download, even now, people who are uneducated, they are able to open the mobile app and they are able to upload the record. So this adoption we have seen. So it's not about patient. The challenge is with doctors. So that if we could make it as a hybrid model, I think then it's a win-win situation.
Interesting. Actually, this brings to mind some concerns that people in general have, right? About standardization of care, about the trust involved in this, data privacy, regulations. I just wanted to bring Kiran into the mix because he has the view from the mountain top, so to speak. Kiran, can you talk a little bit about the exciting things that are happening at NHA addressing this? I know you have a lot of things going on.
Thanks, Arun. And I think that was very interesting to hear, Madhu, in terms of the fact that it is taking off, and that's exactly also what I think we are hearing. So the good part is that from a policy perspective, the government had published the document called the National Health Stack way back in August 2018. There was the committee set up to kind of say how to implement it, which came out of the report that's called the National Digital Health Blueprint. And then the National Digital Health Blueprint recommended that there should be a National Digital Health Mission to actually drive it in a mission mode to kind of completion. So happy to share that the National Health Authority now has been asked to actually bring it implemented. And there is a lot of action going on to make sure that those ideas and those components that are described as the basic digital building blocks that will be useful for anybody who's working actively in digital health in India, it'll actually come to life. So I'll talk a bit about what does this actually mean for various types of organizations or stakeholders, and what it actually will come out from the the National Digital Health Mission. The first and foremost area that it's focusing on is what we call as health information flow. So how do you get, and I think there are many people who have labs today, and it's not very uncommon to have experience in India that you go to a lab and then you get an SMS on your phone saying, hey, you can see your report on your mobile now, right? But that's a kind of a non-standard integration, in the sense that each lab software provider is doing their own way of trying to get the data. But imagine if there is a national standard on how health facilities should be issuing these health records, things that they're already sharing with you. We don't think that they'll be sharing or creating new things. But definitely it's quite common to see across India, diagnostic reports, discharge summaries, definitely already being generated on some kind of a computer. And so we are really looking at how does this come in a very standard way, become accessible to every citizen. So we are looking at how can every individual get access to their records from healthcare providers who want to participate in this. So not only can they get access to their own records digitally, so imagine this as a PHR or a personal health record container where irrespective of where they visit, they're getting their records in. They can now share it with wherever they go with their own consent. So it makes sure, so the way we visualize it, the next time you go to a hospital, you're going to show, you're probably going to scan a little barcode that's a QR code that's sitting on the desk, or you're going to show your phone with a QR code to give your health ID. And then they'll ask, are you okay? You'll get a consent request saying, do you want to share all of your health records before your doctor sees you, and you're going to be able to share it. And then when you walk into the doctor's room, the doctor is going to have your whole history. And then when he generates any information, he's going to add to it. And so you're going to get it back onto your phone and so on. So we are looking to really build longitudinal health records. And this is no more just a conceptual stage. So the basic APIs that are required for this are pretty much done, and they're in the open source domain. There are several organizations that have started to look at this and start integrating it. And we expect to see an adoption cycle. So there is a clear commitment that every public health program and public health institution. So what does that mean? You know, public health touches almost 150 million people in India, right? So between the mother and child programs, the TV programs, the the various insurance programs like PMJ, already are touching over 150 million customers. And the mother and child program actually maintains immunization records for a huge number of people. There are ANC records, and TB maintains TB records. So all of this are going to become part of the individual's history when they go for care some other place, right? So if there is a secondary care or a tertiary care procedure that happens in PMJ, we are guaranteed that hospital will actually add that now into the PHR. So we think that we are going to see an adoption cycle with public health, large corporates, many of these hosted lab information providers. They're all coming forward to say, okay, how can I get this started going as one thing? So one piece that you will see is, this whole thing of health information being unlocked. The next question, and I think, is common is, what does this record look like? Is it in a standard format? Can India actually get to standards on these records? So we are looking at making that happen actually as a so we don't think it can happen on day one. So we do have a model where we are adopting FHIR 4 and health resources from that. But we have a model where you can start with whatever PDF formats you have, but then you don't just release a PDF, but you actually have to add some minimal metadata before you release it. But as you go ahead, we want to actually get you to full standards. And that we think is a journey for each lab information, hospital information system. But I think as they see the value for these things, that they will do it. The third bit is, if you're going to
Kiran, so I just wanted to,
yeah,
sorry to interrupt you, I just want to pause there. This brings up a lot of interesting questions. So let's hold that thought, because it's wonderful that this is coming about, and basically, I think mobilization of this data and access to this data and portability of this data are wonderful things. I think it's going to bring a lot of changes in the healthcare system. But I also want to hear from Stan. He's been looking at this from the global perspective, seeing how the West is responding to this pandemic and how digital health is taking on. Stan, just wanted to talk to you about this explosion of digital health. I mean, even though it was there before, but now the access to this data, the requirement for such data to be instantly available, all that has just exploded. What changes are happening in the US, UK, and so on that you're seeing? And what other changes need to happen to make digital health, go from myth to reality, like we're talking about?
Yeah, first of all, Arun, thank you very much for the opportunity to speak with such an esteemed panel and such a fantastic and large, sizable audience. And again, I think the global perspective is not one that should be dismissed. In the history of the human race, we have never seen a catalyst event, an inflection point in public health like this before. The closest thing we have resembling to this response is the smallpox eradication movement that was led by the WHO from 1955 to 1979, where smallpox was endemic really in the 1970s in 5 remaining countries: Ethiopia, India, Sri Lanka, Pakistan, and Bangladesh. And that was really extraordinary when we eradicated a disease as a global community, everyone from the Soviet Union to India, to the Western countries, to UNICEF, the World Health Organization. Everybody pitched in funds. Indian factories were making the inoculations at extraordinarily low cost, and they were being distributed all over the world. And it took a massive campaign. And remember, that was pre-digital. We were seeing papers being shipped all over the world with syndromic surveillance and with quarantine efforts and with inoculation efforts. And that's the first thing. So we've never seen, in a matter of months, we've seen a global community, every country in the world doing this. Number two, let's understand the myth part of your title here, which is brilliant, because in part, there is some mythology around digital health. Let's look at Vietnam. I have a close colleague, Guy Thuades, who's the head of the infectious disease Oxford Clinical Research Unit in Saigon Hospital, the largest infectious disease hospital in the world, over 500 beds just for infectious disease. And he has been following this very closely, the response to COVID. And remember, Vietnam is a 90 million person country with a massive land border with China where the infection started. They closed the border down immediately. They immediately socially distanced. Everyone in Vietnam was wearing masks. They've had less than 1,000 cases and no deaths. And when I asked Guy how Vietnam was able to do this, his response, I said, please tell me that somehow digital health was involved. Throw me a line here. Digital technology, syndromic surveillance, electronic health records, cell phone technology. What part did digital have in the role of keeping those cases down? And he said zero. He said the culture in Vietnam respects the virus. They respect viruses. There's a history of pandemics there, and they respect the virus. And he said that effectively the social distancing measures, shutting down the country and keeping masks on was absolutely pivotal. Now, that said, what is the reality of digital health? Again, going back to your title. Number three, we're seeing the acceleration of digital health, not by years, but by decades. The adoption of digital health, and really what I study at Columbia and what I've been researching for the last 30 years, again, as a visiting professor at IIT Delhi, is the diffusion of digital. And when you compare what we're doing with the response across the globe, you see very different applications of digital technologies. And it depends largely upon what was resident and legacy for a lot of institutions. At Columbia Medical Center, the medical center was doing about 1,000 telemedicine visits per week in December. Now they're doing about 50,000 a week. So the exponential growth of telemedicine was there, but Columbia Medical Center had been doing telemedicine visits for 5 years. If you talk to a medical center who's just learning how to do telemedicine visits, because remember, telemedicine isn't just copying what you do with a patient in person. Telemedicine is complete re-engineering of the patient experience and the patient journey. That's an important understanding. It requires mapping the user journey, understanding what their experience is going to be through a virtual environment, whether it's synchronous or asynchronous. There are a lot of telemedicine visits that can be done asynchronously. And from a cross-cultural comparison standpoint, there is an extraordinary time here where the health system, the ecosystem in India can leapfrog many other countries and move directly to a centralized electronic health record system, a massive telemedicine system with virtual healthcare. The regulatory climate is critical for the diffusion, the rapid diffusion of digital health and of telemedicine. The regulatory climate in the US has massively changed in the last 6 months. The United States Federal Food and Drug Administration has provided expedited use authorization for dozens and dozens of digital health technologies, so that effectively approvals can be gained in months, not years, in sometimes even weeks. The same thing goes in India. We've seen the same regulatory agencies massively change the regulatory boundaries so that digital health, whether it's telemedicine, whether it's approvals for new digital therapeutics, can be accelerated as well. And then again, remember in India, in the United States, there are boundaries between different states about who can practice medicine. There are boundaries around who can dispense any kind of medical advice over the phone. India, the regulatory climate was already very, very friendly for digital healthcare because there were no boundaries between states and there were no regulatory issues around being able to dispense medical advice over the phone. So in a lot of ways, India is much more progressed than many other countries and really set up for being able to manage this virus better than many other countries. And I think that what we're seeing from a cross-cultural, cross-country, and an international standpoint are, again, it doesn't require digital, number one. Number two, a massive international alignment in using digital, not just to share syndromic information, but share disease information and treatment information. And number three, we're seeing countries like India being able to respond in ways that other countries from a policy standpoint, it might take a month or two just for the policies to align, whereas India's policies are almost made for being able to respond to this kind of event with digital technologies.
So Stan, on that note, there's a burning issue in the US that we all talk about daily, is about testing, proliferation of testing, and how do we make testing more fluid. Real quickly, how is that, when we throw that into the mix, how is that panning out? What are you seeing happening? Because testing, you don't need, you don't have these cross-state border boundaries and all that. So testing is testing. It's just a report that needs to be done. And I know there's a lot of centralized testing and all that going on. There's huge logistic nightmares. What are you seeing happening in that?
Yeah, the testing facilities in the US are coming up to speed. We're testing more people now than we have ever before, but it's still lagging. So when you look at the per capita testing rates relative to other countries, particularly, it's just really hurting. And then that's, I think if you listen to some of the folks that are really leading the way on this, like Bill Gates and others, you'll hear them constantly talk about the need for better testing. And one of the things I'm trying to do is organize a smartphone COVID diagnostic challenge, because again, it's about the diffusion of the testing that's critical to save hundreds of thousands of lives, maybe millions of lives globally over the next year. I'm trying to launch a challenge where we would effectively have a large prize, $1 million, $2 million, $5 million, whatever, for the first team that can invent a smartphone app that can diagnose asymptomatic COVID, and through a regulatory, and it would have to be approved and validated by a G10 regulatory agency, get 1 million downloads and uses. And so testing, Arun, is the center point of controlling this epidemic, this pandemic. Testing is the critical point. So anyone that has any interest in helping me launch this challenge, it would be called the Smartphone COVID Diagnostic Challenge. Please look me up on LinkedIn. We could really use your help in not only getting the funding for this, but also organizing the challenge and launching it within the next 30 days. We have literally the only way to get to the poorest 1 billion people on the planet will be by developing an app. The app and the smartphone are the most diffusive technologies in the history of human race. It's the fastest way to bring a diagnostic tool to 1 billion people. So whatever, whoever listening, or whoever someone knows that can pass this information on, please do, because the diagnostic test is literally waiting to happen. I've seen dozens of technologies over the last 2 years that are extracting and exploiting the high fidelity microphones and the high resolution cameras on the latest smartphones. And these technologies are diagnosing diabetes, they're diagnosing heart disease through scans of the back of the eye blood vessels, through scans of the back of the throat, through scans of the ears, the skin. So these phones, and through breathing tests as well. So these phones are literally right in front of us. Really the key here is just getting some funding and up and running. Please contact me if you know anyone.
Super. So I wanted to say that I hope everyone is listening carefully. We made this a tech-free zone. So you have to actually pay attention to what the panelists are saying. Hope people are taking notes. I see a lot of questions. I want to come back to Kiran with something, but before that, I want to give Kalyan and Vitain a chance to share their views on something that has been highlighted by Madhu and Stan and Kiran in their discussion. It's that this proliferation is happening. It's sort of going to places that it hasn't gone before, in ways that we hadn't envisioned before. So Kalyan, this accessibility that has increased, right? You've been working in this actually to take, for example, teleradiology to tier 3 cities. Silvassa, for example, I remember we celebrated that when we launched your product there. So what are you seeing? What's happening? Is this proliferation really happening? What are the issues? What are the barriers you're facing?
Arun, to start with, again, the topic of discussion today, right? digital health myth or reality. I started the business in a space in digital health that was already a reality, right? Radiology images are already digital. They can be, if you know the techniques, you can easily move them around and manipulate them using, pretty good standards that have been built over the last 30, 40 years. So for me, it was from reality to more mainstream. Coming to your question, one of the things that I am hearing from my original equipment manufacturer, my OEM partners, is that they are, now kind of gearing up for a proliferation of radiology in tier 2 and tier 3 cities. So today, you have 80% or 85% of all your radiologists in your top 10 cities of the country, and over 60% of the scans happening in these areas. And suddenly, what the people and what the people want to say is that, hey, I don't need to travel all the way from a small town in Tirunelveli, to Madurai in order to get an MRI. Right? There is a huge catchment area here. And I'm sure that entrepreneurs and radiologists themselves will understand this opportunity and actually start setting up diagnostic centers. So, over the next 5 years, people are saying that there are going to be over 70,000 radiology machines sold in India. And now people are saying that the majority of that is actually going to be not in your top 10 cities, but in your smaller cities, in your Ramnagarams, in your Begusarais, in your really interior areas of the country, which are still dense, because that is what India is. So I am seeing this across the country. And I think it's an exciting trend because this gets high level and quality diagnostics much closer, right? Digital health is important because I can give access to the specialist, but somebody has to physically set up a center and the machine in order to do something. And definitely, I think that the COVID situation has exacerbated the need for that. And I think overall, it is definitely a positive for the ecosystem if you look at it.
Excellent. So you bring up a interesting point, and I want Biten. I know Biten has something interesting there. This width and breadth of proliferation happens, but Kalyan is also saying that there is a depth that is happening, and there is a last mile delivery that needs to be figured out so that this becomes more of a reality, right? From myth to reality. So Biten, I want you to talk about what's happening vertically in doing this depth, making this happening, and there is sort of this opportunity that has opened up to innovators, right? I know you're part of a huge organization, but I know how you function. It has to be lean, and it has to also be, innovative thinking to keep yourself viable and keep yourself relevant. What are you seeing happening? Can you give us some examples of this depth of penetration, the last mile innovations that are happening? You're on mute, Biten.
Yeah. So, Arun, thanks a lot for the question. It's been wonderful discussions till now. Let me first address the title of today's conference, right? I think hopefully by the end of today's conference, we should drop the word myth, because if digital health is not real now, it never will be, right? Before I get to a couple of specific examples, let me start with highlighting three very critical aspects, which I believe have been personified by COVID, and I think will become the accelerators going forward. So number one is, I believe COVID has brought in what I call as equality, and it has brought in leveling. It has leveled the playing field for large companies and for startups. It has leveled the playing field for all the stakeholders across the value chain. The people who are keen to deliver value, and the people who are keen to capture value in terms of healthcare. More often than not, one of the reasons why digital probably had adoption challenges is not because it had, technology was not real or technology was a myth, but it was because somebody in the value chain saw it as being disruptive to their business versus others saw it as adding value to the business. But with COVID, everybody is seeing disruption, so it's an equalizer. The second part is, it has therefore either removed the bottlenecks which existing on certain use cases, whether it's the first mile or the last mile, or it has opened everybody's eyes and minds to new use cases. And then finally, the third part is that for long, when we talk about healthcare, the biggest problem which everybody was trying to always address, particularly in emerging markets and in India as well, was the A of affordability. Today, again, going back to the, coming full circle to that question of being a leveler, now suddenly everybody's talking about, well, affordability is still a challenge and we'll figure it out. But the leveler again is access. And that's where digital health starts playing a big game, which is making healthcare accessible even to those who had all the access to the healthcare, because today it's inaccessible to even to the people in urban areas and the paying patients, right? So I think these are the three things we need to keep in mind. Now coming to simple examples in terms of what organizations like us are doing, right? So just to highlight all these 3 points, I'll give a specific example. I lead R&D and innovation for the disposable contact lens business of Johnson & Johnson. Now, when you take a look at a COVID-like situation, right? Eye care practitioners, whether it's clinics or shops, shut down. All of us in the company as a large corporation working from home, patients sitting at home. I'm a contact lens wearer since 25 years. Where do I go? I need to get my supplies. I have only two options. Either I get my supplies for my contact lenses or I switch to glasses. If I as a patient switch to glasses, the company loses out, but even the optometrist shops, the retail outlets, the doctors, everybody loses out. And there's no guarantee I'll come back. In fact, the dropout rates can be as high as 30%. 30% of the people don't come back when they move away from contact lenses. So sustaining becomes a critical part. Sustaining access to the consumer who's already there. Forget the new consumers you want to get access to through digital. Even sustaining the existing customer becomes a challenge. So we had to very quickly work with regulators in the Asia-Pac countries and get them to understand that the people who are holding prescriptions need to get regular supplies. And then we had to work with the doctors who saw digital as an enemy, because they thought as soon as companies like us started sending the contact lenses at home, they would lose out business. The consumer would not come back. But today, we are being able to actually tell the doctors, you don't have to worry about the supply chain. The patient will still, come to you through telehealth. They will reconfirm their diagnostics, reconfirm that their current prescription is okay, and you send the orders to us as you were sending earlier. But now, instead of sending the order to your shop, which is closed, and the patient does not like to travel there, we will just ship it to the patient's home. So as simple as that last mile small change has made a big impact, and we've been able to pretty much keep most of our existing consumers, but it has now given us confidence to now bring it to future consumers. So a last mile opening up on existing customers is going to change the business model for many. And today, our ECPs, who just about 4 months ago were saying, eye care practitioners were saying that we will not allow you to ship the product to the customer, are actually coming to us. Even our competitor companies, eye care practitioners are coming to us and asking us to make them the distributors and retailers, or they want to stock our product because they know that they have confidence in Johnson & Johnson being able to ship the products to the consumer's home. So this is an example of what I mentioned. It's leveling access, it's opening up new cases, and it's bringing in the last mile and the first mile into play here.
Wonderful. Thanks for that, Bitin. I want to get back to Kiran. Sorry, I cut you off in the beginning. This brings about a very interesting problem, I don't know, or a challenge, is this huge data flow that is going to happen. Actually, both Kalyan and Bitin touched on practitioners' data too, right? It's not, so you had some mentioned a little bit about handling doctor data and things like that. You mentioned about this consented flow of data and how it's going to impact. I just wanted to, the question about privacy, and there have been some questions in the panel, in the Q&A, about maintaining this and what are the barriers to sort of keeping this preserved. And the added dimension to this, Kiran, is this is huge, rich gold mine of data that we'll be sitting on as soon as it becomes live. what are some of the plans to actually generate productive use of this data, maintaining silos, maintaining privacy? Is it possible? Or are you seeing that, this is all going to turn into a huge mess of violated confidentiality? What are you envisioning?
Yeah, not at all. In fact, I think we have the advantage that there's a lot to learn from what has happened in other countries, other parts of the world on what not to do. And so if you actually look at, so let's just first break up this data problem into, what is the legal framework that governs this whole, this one, right? So when it comes to health data and fully personally identifiable health data of an individual, it will come under the Personal Data Protection Bill, which is sitting in Parliament. We largely know the contours of it, so we're waiting for it to kind of get passed. And that puts very clear responsibilities on the roles of the data fiduciary and all of the intermediaries in that. And now the consented architecture that we are bringing about under the National Health Mission is fully aligned with the Personal Data Protection Bill. So I think there is two things that you should know. That one, only you can access your health data if you seek to do so. The whole thing is voluntary. If somebody does not want to keep their health data, they don't have to. If people want to maintain compartments, like for example, we think that people may want to keep, sexual health data there, say HIV related kind of data, either as separate or, they don't even want it part of their records for whatever reasons, because it might have some implications. Even when you're sharing and consented sharing, you can decide not to share everything. Of course, your doctor will get a little note saying that you didn't get everything. And, he can then talk to you saying, look, if I don't get all of your data, then I can't give you proper treatment, but you still have the right. And you have the right to say, I don't want to participate in all of this. So it's completely user-centric in design in terms of making sure that it's about empowering the user and any other way. It's absolutely not centralized. So it's a very federated architecture that's been built. So it's not like there's a single place you can hack into and get everybody's data and so on. So a lot of thinking has gone into the design to make sure that we get that right. Now, when it comes to, one of the things that the whole health stack is supposed to do is not just allow you to get these personal data flows to happen, but it's also supposed to make two other things happen. The second thing it's supposed to enable is what we call as aggregated data flows. So imagine that a participating lab is sharing how many patients it saw, how many tests it did, how many HIV tests it did, how many of those were positive, how many HbA1c tests it did, and how many of them were outside the range. Absolutely no personal data, but aggregated data. Now these come under a completely different law. In fact, the government has set up a committee under Chris Gopalakrishnan, which is right now debating, what are the set of laws or the ways that would be governed for non-personal data. But fundamentally, this would be very rich analytics data that would be useful for policy and policy making that would happen. And the government is really looking at how does this get into what's called as the national open data policy, where it is going to become widely available to the ecosystem in many ways. And the third area that we are looking at, and that's, I think, still very early and will take some time before it actually happens, is truly anonymized data, but with enough details that make it possible for people like Kalyan to actually, say, build new AI models or stuff that actually requires a very significant amount of details that go in for their training. So that, I think, we are still early stages, so we wouldn't want to comment too much about it and how that would work. But Niti Aayog has been doing a lot of work and thinking in terms of how that should kind of happen. And I think those interested should also start following some of the thinking. But that's the crux of it. So I'm fairly confident that this is actually going to be good for all the players in the ecosystem, Arun. And I hope I answered some of the concerns and questions related to this.
I already see you answering some of these on the panel. So I'm just highlighting some things that will be of, not panel, I mean the question answer box. But I'm just bringing some of these out so that the general audience also gets this, because I asked them to listen. Interesting. So you're saying that there is a possibility of this data being available to innovators, and people should really watch out for that.
And that is the intent.
I know.
Real intent. I'll just add one more thing, because you asked me about doctors and I didn't talk about it. Now, one of the things that this whole digital health mission is also doing. So let's say we are talking about a piece of data, like let's say there is a a diagnostic report or there is a prescription, right? Now, attached to this, we really want to know, who is this about, right? So you need a way in which we identify an individual digitally across the healthcare ecosystem, or in a health interaction, you need to know, okay, how do I identify Kiran, or how does Kiran identify himself digitally so that I can give this record to him? Two, you need to know which is this healthcare institution that issued it, right? If it can't just be a label on the printout kind of a thing. So every facility that needs to participate in this ecosystem, every doctor that needs to participate in this ecosystem is actually going to be part of what we call as registries. So there are digital registries, and there is a whole process on making sure that they are really authentic and real. So when you look at a record, it's also fully non-repeatable, right? Because it has to be used, say, probably in, say, medico-legal scenarios in a court of law. So the design also makes sure that you are actually dealing with entities. So for example, telemedicine, as Madhu is saying, is growing at a fairly rapid rate. And one of the things that's being asked is that a real doctor on the other side? So how do you know that you have verified credentials on the other side? How do you make sure that the doctor can e-sign and you can actually get an e-prescription as part of the teleconsultation? How do you ensure that he can actually see your medical history? Now, the health stack is actually giving you all of these things as part of a kind of a digital building block. We call this as public goods, which are enablers for the private ecosystem, right? So we are going to actively work with people like Madhu and people, other telemedicine and other players who want to use these APIs to create these kind of solutions. And that's really where it's going.
Excellent. So I'll go back to Madhu, who's been patiently listening. Madhu, you talked about revenue being this great driver for adopter. I know that in the beginning stages, the struggle was to get the doctor to use the EHR system so you can do wonderful things with it. Now revenue, you see, is a great adopter because walk-in revenue has stopped. Do you think what Kiran is talking about would be a great sweetener about this registry? And what is the other thing that needs to happen? What do you think will make them adopt? What are you seeing happen? Because you mentioned something like 8,000 video calls happened or something like that, right? That's phenomenal. So what do you think will make them flip?
Definitely, with the help of government, we'll be able to integrate this in one platform. If that happens, then if we have unique key across wherever we go, we just share the key, and based on the doctor partitioned data, if I'm going to a dentist, I don't have to share my cardiology reports to him. So likewise, if we have that kind of flexibility, that's a dream come true. If government is bringing that kind of initiative and make doctor to adopt and follow the standard, then we'll be somewhere in another 5-10 years in digital health. But one thing is, what is in it for the doctor, what is in it for the private hospitals need to be clearly defined, because they all see today digital health as something as a luxury item. It's not a mandatory, or it's not something which they feel it's must to have. So that need to be somehow, we have to make it mandatory. So any patient who comes, how the records, irrespective of whatever the cloud you have, it should also go to the registry so that it is noted. You can give unidentified data based on the patient privacy, whatever it is. Patient will ultimately have their rights, whether to share it with others or not. But aggregated data at least should go to the registry in a centralized manner, so that tomorrow if some issue comes up, we'll be able to get the disease condition, where it is prevailing, before even it grows, we'll be able to arrest it. So this is very good initiative from government if things go well.
I think that's exactly what Kiran is talking about without specifically mentioning, but I think that's a great point. Just wanted to shift to Kalyan. Kalyan, I know you've done this AI experiments and all that. You've reduced response times.
Yeah.
You are actually trying to implement something like this. What Kiran is actually talking about, like a protected sandbox of data, but you've actually started playing with it, right? And it started yielding some results. Can you mention a little bit on that, and anything else you see might actually be good inputs to all of us in seeing where the path from myth to reality is progressing?
Sure, I think that and I'll be specifically talking from the radiology side. In radiology, the data format is very straightforward. Everybody knows what it is, what are the exact headers, what it looks like, how you can manipulate it. Basically, what essentially happens is that as 5C network, we are now collecting over 50, 60 GB of data every day of radiology data. And what we have seen is that access to quality tagged data is obviously the biggest barrier to innovation. And our idea has been, hey, there are obviously a lot of data that we are using with due consent. There's a lot of data that we are using to build our own models and try to improve our service levels. But radiology can literally diagnose a million things. And for one company to go do that is absolutely impossible. I'll probably have to hire 20,000 data scientists. And with all this data today, we have done over a million cases. The idea is that we are looking to build these sandboxes, and we're looking to actually allow first, test the efficacy of these models initially, then test them at scale, and then potentially allow them into our network as value providers to the whole aspect of radiology that we are providing. So there are already a couple of AI providers who have passed muster in terms of being able to deliver quality diagnostics, something that the radiologist is valuing. And they have actually been brought onto the platform, and their inputs are seen by our radiologists, and they're using it to take action. So very similar to what Kiran said, I mean, we're building this API-based sandbox that allows players to plug in, train if they require, test, and then that allows 5C to choose solutions that radiologists truly need, and actually deploy them at scale through 5C, and which will actually improve the quality of reporting, the turnaround time, and therefore the healthcare outcomes that come out of radiology.
There's a question in the panel that I think is appropriate to address now, is saying, what are some of the actionable insights and foresights you're getting from the data you're gathering? Can you take 30 seconds to answer with a specific example, how it has improved your functioning, how it has given you insight?
Sure. So
same for Madhu also. The question is for Madhu also. So I'll just quickly swing to you also.
I'll take a specific example of brain bleeds, which is a very, very big problem, right? And incidentally, Rajnikant's daughter dies of it in his latest movie. Sorry for any spoilers. But it's basically a very, very big issue, right? And essentially, if you do not diagnose it and if you do not treat it in a very, very short amount of time, the patient has a significant chance of losing some form of movement, or in the worst case, his or her life. And what we did was we actually built an algorithm that helped us understand what type of bleed is present in a scan that is coming to us, right? So is it extraparenchymal, intraparenchymal, etc., etc., etc. And we were able to reduce cases that we considered critical from a turnaround time of 39 minutes, which is already pretty fast, to an average turnaround time of 18 minutes. So if our algorithm flags a brain bleed, I return that report within 18 minutes. And in most cases, that person is, being operated on, or at least the neurologist or the treating physician knows what to do within 30 minutes, right? That is decisions that are being taken. And even in terms of accuracy, radiology, what many people don't realize is that even radiologists make mistakes, right? And on 5C, we used to have, for brain bleeds, an accuracy of around 98.2%, especially for identifying even the smallest of bleeds. And we are now at 99.7, right? So while we may flag a few false positives to the radiologist, they are able to use their expertise and quickly filter out what they need to flag as a bleed in the report and what they don't. And really small bleeds, which they would have missed, right? The AI is actually able to help them say, hey, no, this is a bleed and this could potentially be dangerous. So a real live use case that is, and we see more than 500 brain CT scans a day on 5C today, right? So this is actually AI applied at scale that is being used to save lives.
So Madhu, I just want to swing to you. There's also a question on the forums that is asking about EMR has already failed even in the West and all that. And so where do you think this is going to go, right? What is that leapfrog, right? So there's a very interesting question, right?
This is very interesting question, yes.
You and I both know that the doctor adoption of EMR was a big problem. I opened my mouth, maybe I'll get into trouble, so that's okay. But it seems like things are turning around, and revenue was a driver, and we've talked about this diagnostic. But where do you think the next leapfrog is? I mean, there's a suggestion of smartphone, etc. What is your insight? What is the insight you are getting from the data?
So what we have done, EMR adoption is a challenge across the world. Everybody knows about it. And if we leave that in paper and nothing happens around it, it's going to be, and just changing a paper by scanning and then making it digital, calling it as a digital EMR is not right. So what we did to increase the adoption is we gave every doctor with an informatics secretary who could capture data as data on a real-time basis. So this data as data capturing on real-time basis gave an e-prescription to every patient, printed legible prescription. Also, simple use case is that the minute I come out of the doctor's office, I immediately know what is my waiting time in the pharmacy, how much is going to cost me. I don't have to go to second floor and see, because data is already gone there. And also, if I need to take an X-ray, then how much it is going to cost me. Everything is transparent and clear once data becomes data there. So the EMR adoption is a major challenge, and we were able to crack it through giving secretary to every doctor, because that's the only way we thought the doctors will change. Otherwise, they are not going to type, and we cannot blame them also, because in India, 3 minutes per patient. Can you expect doctors to type or do anything taking attention? Even patient will get irritated because they feel that I have given money and he is typing something in computer, not giving me enough attention. So this girl who is carrying iPad and Wi-Fi printer, everything, she types it and immediately data captured. And also the prescription medicines, clearly we'll send it as a reminder to the patient, so they follow any adverse effect, they can record it. Immediately we get it in our disease management team, and we'll be able to tell the doctor, is there anything you want to change the dose or anything. So this entire thing is possible because of EMR on a real-time basis.
Okay, great. I mean, we talk about change agents in user behavior change. You actually have live human agents making the change happen, which is interesting.
Actually, we started with just 20 people. Now we have grown to 350. We have got a contract for 350 people. So people are adopting. Doctors, especially old doctors who are so busy, they love this concept of having some secretary who types everything for them and gets everything, so that they see in the mobile phone what's the patient condition last time, what's the trend graph is telling, is that phosphorus and sodium is in proportion or not, everything he is able to see.
I mean, we are running very close to our end time. I'm going to take a couple of more minutes later. I'm going to mark that up now. But Stan, I wanted to swing to you, and there's this interesting explosion of this happening, leveling happening, and there's also innovation and collaboration happening. This is something that I remember you touching upon, that there is this technology and practitioner collaboration coming together that's happening in an awesome way. So can you take about a minute or so and talk about that? And also, there's an interesting question in the chat box asking about, you mentioned that now Asia can be leaders, and this Asia factor is now coming into the whole data equation and the AI ML equation. Can you also touch upon that a little bit? About a minute or so, please.
Yeah, thank you, Arun. I think the idea here is that the manufacturing processes have going back to the teamwork and just the cross collaboration, whether it's a manufacturing process or whether it's a clinical trials process. We're seeing vaccines. Let's not forget the role of digital in life sciences. I think that's something we haven't really touched upon today, but I can't emphasize how important that's been, whether it's AI being used in the rapid virtual trials for the vaccine, whether it's the e-consent and the virtual recruitment for clinical trials, or whether it's the virtualization of the execution of clinical trials and the data collection of clinical trials using videos and other types of tools to collect data remotely from patients who have COVID, who are dosing and now double dosing. So that's absolutely critical, is the rampant digitalization of these technologies in life sciences. We've never seen that before, and that's extraordinary. Going back to the ability to leapfrog a lot of health systems, I think that we're seeing today, and particularly with this smartphone COVID challenge that I'm trying to launch, and again, anyone who would like to help, please seek me on LinkedIn. This idea, a lot of these technologies are being developed by people and good friends of mine have been teaching in India since 2006. So I've developed now over 1,000 alumni from IIT. I have hundreds and hundreds of other friends at various departments and universities. But training algorithms needs two things: really good computer scientists and lots of patients who have the specific condition you're looking for. And so right now, there's no better place than finding a lot of asymptomatic COVID patients than India. And so you have no better place. I mean, India is the intellectual capital of the world. You have no better place for computer scientists than India. So launching this COVID smartphone COVID diagnostic challenge would be, I think, my guess would be probably invented in India. So this is a leapfrog opportunity, not just for the health system, but for many of the scientists today in India.
Excellent. Biten, this is a beautiful culmination of how the innovation chain has expanded, how this practitioners' behavior with innovation and tech has sort of intermeshed now and it's expanding. How is the industry responding to this? There is an important aspect of capturing and delivering value to each one in the chain, right? We're talking about, so I think Kalyan touched upon this, right? That we can go till, data leads to at the tier 3 city level, but then there has to be a physical machine and a physical person doing some last mile effort. You also touched upon this in the delivery. But if you look back, and there's an interesting question on the forum about how are equipment manufacturers doing this? How are they responding to this? What is the value that it brings to them? I think you're the best placed person to answer this. What are you seeing happening in this value chain? How are people responding to this, and how do you think this will proliferate?
Thanks, Arun. Let me, I try to answer the question on the Q&A, but let me try and reiterate a few critical points here, right? So, when I spoke earlier, I talked about the last mile. When we talk about equipment and particularly diagnostic, that brings into play the other extreme of the value chain, which is the first mile, right? And I think Kalyan's highlighted some, super examples on what AI can do. But even before that, it's the baseline access and connectivity between a healthcare practitioner and a patient, right? Because that's where you open up the opportunities to potentially start capturing data before AI can come into play, right? And we've seen a great example with what Madhupala and her team at Emcure are trying to do, right? They're opening up that first touch point, right? And I can tell you that we are looking at all possible use case scenarios. Very encouraged by what we've seen in the last mile connect and how business model disruption is now, there's a strong willingness across stakeholders. Now we're bringing that into the first mile. Portability of equipment is being seen in a completely new light. Earlier, portability was seen again from the perspective of rural access. Can I put it in the boot of a car and bring it to a rural area and get diagnostic and testing done, right? And then if we can, by the way, also have a doctor go along with it, then you can give a prescription online and bring them to a tertiary center, right? And Arvind Eye Care Hospital is a classic example of how they have done cataract surgery for a very long time by creating that pool of patients to come to their tertiary sites. Today, with the culmination of all these digital technologies, with telemedicine, the doctor doesn't have to go there, right? So imagine, Madhubala's model where a rural patient on a telemedicine is able to get a prescription to get a diagnostics done, right? And with portability, the doctor doesn't have to be there. These portable handheld equipments, and we are seeing in real time in eye care, where you can pretty much have a basic optician or even a technician go and just do a simple aim in the eye camera, capture the image, and everything else is going to be done on AI. And we are already test bedding some of these examples. And I'll end by saying, in the last 4 months, having engaged with the APAC Med community here in Singapore, which looks at innovation in healthcare across Asia Pac, we've seen more than 50% of startups who have been applying to the APAC Med grants or innovation challenges being in the digital space. And 50% of those are actually coming from India. And I went in with the mindset that if I find one in the eye care space, I'd be I'd be happy. I found 7 in the eye care space, out of which 4 came from India. So to Stan's point, if there's a place to disrupt this by bringing all these technologies and health stacks, as Kiran mentioned, combine that with policy and then leapfrog, I think the place is in India, and companies like us are no longer cautious, but I would say we want to leapfrog because we know if we don't do it, then the likes of Kalyan are already doing it. The likes of Madhuwala are already doing it. So we have to just leapfrog together. And I'll just add one more point, Arun. When we talk about standardization with these tools, let's not forget that there is tremendous value in the genetics of any data set. And we all know that the largest genetic data sets and data pools are going to come again from China and India. And China has taken certain policy level decisions in terms of how data for digital analytics goes and is utilized. They don't allow data to go out. Initially, companies found it very difficult to work with them, but today it's becoming a big value add because they know that the data is centralized and everybody can capitalize on it. And I think with some of the stuff which our government is trying to do, what Kiran just explained, that aspect of genetics is going to open up even more opportunities when we talk about data analytics. Arun, you seem to be on mute.
Arun, you're on mute.
Yeah, there's some noise here, so I muted. Thanks. That brings us to sort of the end of what we want to discuss. And here is the best time for something I do in all panels to wake people up who have gone to sleep, is to put panelists on a hot seat and ask them a very pointed question. And I'm going to start with Madhu. Madhu, your question and to be answered in about 30 seconds or less thereabouts. So the controversial, the provocative question for you is this, right? So digital health is proliferating, and do you think buyers are convinced, payers are convinced that there is a long-term revenue stream with digital health? And do you see a stable business model emerging for innovators out of this?
Yes, there is. Yes, and provided they could understand where the money comes from and what is the value they will pay for that particular service. If these two answer, then yes, there is money. But we cannot come up with something which people will not use and try to do. That will not work out. If there is value, yes, then there is.
The second part was, as an innovator, as an entrepreneur, do you see a stable business model emerging?
I mean, we've sustained for last 7 years. So definitely it's a stable, it's there. Stability is there. But entrepreneurs need to know two things to drive adoption, to drive revenue, and make it as a self-sustaining model. If this is the answer, then yes, digital health, they can choose digital health as this one. Otherwise, it's going to be a challenge.
So Kiran, next, so your 30 seconds or less. So we are all here to create impact. We want great things like equity of access to healthcare, equity there, lower cost, improvement of quality of care, and all that. Do you think these are possible with the initiatives that you're doing? How are you convinced that these things are going to improve in such a massive, fragmented, and jugardish system like India?
Absolutely. In fact, if there is anything that can that I'm very optimistic about, that it will happen in India. So it's very interesting as to, in my mind, how at least just these ideas that and all of these concepts that we've been looking at, the response that we've been getting from the stakeholders, from the industry, makes me actually very filled with optimism that many of these things can happen. They are not difficult. I think it was really a question of having a certain set of catalysts, having the government play the right role in terms of enabling and becoming an enabler. We have this phrase that it's public infrastructure and private innovation. The jugad or the jugalbandi between these is what will actually make the change. And the examples in our mind are what has happened in UPI in terms of financial transactions and payments, right? And it's a classic example.
30 seconds up. Good, very good. Stan, you are on the hot seat now. You're talking about collaboration. You're talking about data flow between countries, between cultures, and all that. this is going to really create some hotspots of innovation. So for all the innovators tuning in here, I wanted to put you on the spot and ask, where do you think this is going to happen? What are these hot areas that they should be looking at and throwing in, other than your app that you plugged?
Yeah, it's a very good question. And what we've seen in the history of humankind is that certain inflection points, whether it's a war or whether it's an environmental catastrophe, can either decelerate or accelerate certain innovation, either regions or cities. And so we've seen this, for instance, just over the past year, now 6 months, over the last 6 months, we've seen this happening across many countries. I think that the big points, a lot like what we've seen with the Patents Act of 1970 in India, that accelerated the growth of the pharmaceutical industry because of, number one, the intellectual capital that India had resident, and then the amazing natural resources that India had in its land. It could sustain and make amazing stainless steel, amazing glass products that were needed for the pharmaceutical industry to produce first-class products. And then obviously the intellectual capital within India and all the biomedical scientists, all the various engineers that could build these factories and create pharmaceuticals. And so now when you look at not only the computer science population, but also the biomedical population in India, it's extraordinary. It's absolutely extraordinary. And so I think that a lot of that will depend on where the vaccine is not only invented. So who's going to come out with the vaccine? It will be a company from India, it will be a company from Israel, it will be a company from England or the United States or Canada or China. I mean, and then where does it get manufactured? Now, you tell me, where have we seen the most HIV medications manufactured over the last 20 years around the world at cost or below cost? India. And so I think that there will be a secondary race that will occur here that will spur even more innovation, and that is the manufacturing base. And as you know, there's always been a little tension between China and India. And so I think that this will spur another point of tension in terms of the bidding for the country that can make 5 billion vaccines over the next 6 months. And I think that will spur a massive amount of innovation, because you're going to need tens of thousands of scientists and engineers to make the factories and to then create the manufacturing process, the supply chain process. So I think we're looking at a very interesting point in human history where, whether it's Bangalore, Mumbai, it's Delhi, Hyderabad, we don't know where this will occur within the subcontinent, but my guess is another city or two cities will become the hub of this manufacturing process. And I hope some of the people listening will be able to be a part of that, because we're going to need the very best to do this.
Dan, I have two more hot seat questions left. Kalyan, if all this access is happening everywhere and great things are, connectivity is there and all this is happening, do you really see costs going down, margins taking a hit? Will entrepreneurs still make money? Because, this is going to be a democratization of that. It's going to be a commodity product.
Again, I'll speak specifically about radiology. The biggest cost in a radiology center is essentially the amortization cost or paying back that machine. And if you're able to massively scale numbers, entrepreneurs themselves will reduce costs. Like in places like Chennai, I mean, you can get an MRI for less than $1,000. But if you actually go interior of Tamil Nadu, the cost of MRI starts increasing because the demand is less. I believe that as you democratize access, costs will reduce, margins will reduce, but overall value created and wealth created for entrepreneurs will actually increase.
Super. Excellent. Bipen, the last one on the hot seat. 30-second answer to, if this leveling is happening and access is the enabler, it almost looks like small entities and innovators and entrepreneurs will open the door and big companies will walk in. Is that true and take over? Where do you think digital health will take us with that aspect?
I think it's not about big companies will walk in, but I think big companies are today more amenable to collaboration. So they will walk in hand. And I think that's good for both, because what you're doing then, in essence, you're creating an ecosystem where, small scale and large scale companies can actually complement each other's skill sets, the agility and the size and the investments, right? Bringing, large companies have the investment potential, but sometimes they lack agility or the mindset to challenge their own business models. And that notion is what small scale companies bring in. They bring in the agility, and they don't have any baggage, so they are willing to challenge the status quo. So if they can figure out a way to work together collaboratively, and I think lots more companies are recognizing that today more than ever before. And in hindsight, it's at the end of the day, let the patient, let the consumer win. This would open up a lot more opportunities for mergers, acquisitions, licensing, whatever you call it. So long as the consumer wins, be it access, be it affordability, that's the end game.
So that actually brings us to the conclusion of the webinar part, and we actually overshot into question time. But I'm not too worried, because I think almost all of the questions have been answered by the panelists. There are a couple of minutes left. I want to answer 2 questions. I'll just open up to the panel and see whoever wants to take it can. This last mile connect of digital health depends a lot on infrastructure being upgraded. And there's also this question of about having sustainable revenue models for those entrepreneurs. I think, Kalyan, you touched a little bit upon that. But maybe Kiran or Stan or Bitin, can you talk about the last mile infrastructure to be upgraded to get to this, so that the base of pyramid, the rural population, also participates in this revolution? I don't know who wants to take. Kiran, you want to take that?
Yeah, sure. So I don't know, when we say base of pyramid, what kind of scenario we're looking at, right? So most of healthcare that India provides is still slightly urban. Even when the moment you start going at a taluka level town, you'll find something, and their connectivity is reasonable already. Even our fiber optics have reached that level. So if you're really talking about, PHCs and now the new health and wellness centers, that's another matter, because there are connectivity challenges. If you're looking from a consumer perspective, I think you should just look at the numbers, what our Jio and others are producing in terms of their digital reach and what digital consumption has gone through in India. And so I think I'm personally very optimistic that I wouldn't, sometimes rate of change of these are really exponential, and I think our human mind cannot see the exponentiality of it. I wouldn't today design any system. Now, I would make the assumption that it's just not very far away before we really can live in connected worlds. I remember 10 years ago, if somebody told me that the only kind of a music player I could have was a streaming player and I could not store the music, I wouldn't have believed them, right? So
this is the last question. There's an interesting question. I'm sort of combining a few questions in here. There is we're all very optimistic, and we're talking about collaborative use of data. Do you think people will actually, the term used in the forum is donate this data, or is there going to be, ring fencing and competition for this data? Where do you think this is headed?
Arun, let me take that because again, I have a classic example for anyone who wants to look up. Just Google up something called as Project Yoda, YODA. This is a live and one of the biggest examples of data sharing across pharmaceutical companies. And this has been live. In fact, J&J started this about 5 or 7 years ago on one disease area, and now it's proliferated across multiple disease areas. And it's a live example of multiple companies are on a subscription basis sharing data. And once you become a member of the data consortium, it's up to you to decide. You got to do 2 things. One is you either pay in terms of data, raw data, or you pay in terms of getting access to the data, or both. And once you get access by participating through this payment, it's up to you in terms of how do you analyze it and what intellectual property you generate out of analyzing the data in your own way by building your own algorithms is completely up to you. And what was critical was, although J&J was a harbinger, we actually never owned the ecosystem. We found a neutral body like Yale University to be the harbinger, the convener, and the owner to drive this community. And that was a critical differentiator. So there are like 5 or 6 major companies who are participating in this. At a ground level, we are competitors, but when it comes to the data consortium, we are all collaborators. So finding that neutral body, laying down the ground rules where everybody agrees to, and then everybody pays for access and sustaining the database. And the second one is pays in terms of contributing their own data. That what get you access.
Wonderful.
Just look up
Excellent.
Project Yoda. It's
Sure.
real now.
Excellent. So I hope everybody listened to that and took all that. So we're going to stop here. We're already 3 minutes over. I want to be respectful to all the participants. I want to take 10 seconds to thank all the panelists. I'm not going to do this individually, but I've had a lot of fun listening to you and putting this together. I know time is really valuable. You're all pulled in 100 different directions. I really appreciate you taking the time to be part of this. Thank you. I also want to thank HITLAB, our partners in sort of putting this together and doing some of the background work and getting this, and the Villgro India team who have been patiently doing all the background work, silently making this happen. Hey, thank you all. Thanks to all the attendees. We had something like 95 attendees at one point, which is amazing. I hope it was interesting to you. Please stay a few more seconds and fill up the feedback form that pops up. It'll give us a lot of insight into designing future webinars. Thank you all for participating. Thank you. Hope you all stay safe and sane in these trying times. Thanks.
Thanks, Arun. Thanks for conducting this.
Thanks, Arun. Thanks, everyone. Take care, everybody. Stay safe.
Thank you.